Okay, so we're online now at this webinar, which is sponsored by Boston and has brought together some of the experts in pulmonary embolism, thrombosis, respiratory medicine, renal medicine, and interventional medicine from all around the world. We have a stellar faculty, and I'm really glad that we're able to see people from all around the world joining us. We're already bumping 50 people online, which is fantastic. I know you're all busy working hard in your hospitals in really quite stressful circumstances right now for all physicians in all fields. I'm Andrew Sharp. I'm a cardiologist from Cardiff in the United Kingdom. And I'm going to move straight on into the faculty that we have, which is from a whole range of subjects. We're going to start with David Jimenez from Madrid in Spain. Now, Spain have had it pretty hard from COVID. This is a virus that came out of the blue only a few months ago. We're all still learning our way with this disease that we seem to have seen an association with thrombosis. We're going to explore that in this webinar. And we're also going to understand a bit more about COVID and how it affects various organs in the body. So David is a respiratory medicine specialist. So I've asked him to talk initially about how COVID affects the lungs. And David, if you could just give us some background on what you're experiencing at the moment in your hospital in Spain, and then tell us about how COVID affects the lung.
Thank you, Andrew. We had a huge experience in my hospital in Madrid. In fact, this was the hospital in Madrid with more patients attended with and admitted to the hospital with COVID-19. We had peaked at 1,100 patients with COVID-19 at the same time. And of course, the things that we saw with these patients and the effect of the virus in the lungs is very similar to what we have been seeing with other kind of respiratory virus and respiratory diseases. In fact, these are patients who present to the emergency department with bilateral pulmonary infiltrates, with very severe respiratory insufficiency. And for those patients who didn't make it and those patients who died, we have some data from the autopsies showing that these patients had the common findings from acute respiratory distress syndrome, which are diffuse alveolar damage and some kind of microthrombosis, which is also a frequent finding in other forms of acute respiratory distress syndrome.
And how are you handling these patients? They're presenting very sick, very hypoxic. We've had a lot of debate around the world about what mechanisms we should be using to support these patients. Early versus late intubation, CPAP versus invasive ventilation. What sort of proportion are you sending to each therapy at the moment?
Well, I'm not an expert in advanced respiratory therapies, but my colleagues always say to me that these patients benefit from very early intubation and a delay of intubation with the use of non-invasive ventilation or with high flow prones make the patients, the prognosis is worse. So early intubation for these patients with acute respiratory distress syndrome and prone position for most of these patients at the very beginning.
And there's been some discussion about possibly two phenotypes of respiratory insult in these patients, whether it's a direct viral pneumonia versus ARDS. Do you wish to talk about that? So do you believe that there are two phenotypes, or do you think that's been overblown?
Well, there are some reports, and I have to say that we all agree that they are very low quality evidence around these, but there are some reports suggesting that there is a cytokine storm for some of these patients, and in this sense, we use some laboratory biomarkers to try to identify these patients who are developing a cytokine storm and are developing acute respiratory distress syndrome, such as PCR, D-dimer, ferritin, something like these markers might help identify these patients who are going to develop very severe respiratory insufficiency and who might benefit from some immunosuppression or anti-inflammatory drugs.
Okay. I see that Menno Huisman's on the call. Menno, are you able to raise your hand, and I can just draw you into this discussion at this point. We'll see whether he can. Okay, great. So I can now bring Menno across.
Yes, hello.
Yeah, Menno, hi.
Hi, good. How are you?
Yeah, very good. Thank you for joining the call.
Sure.
So
I may
know-
not be able to be there all time, but I already learned a lot from David, and I'm appalled by the number of 1,100. Then we are in a luxurious position in my hospital. This is so gross number. So that you have challenged this, David, and can still smile. This is incredible. So thank you for this, David, and for your patience. Really.
Thank you, Menno. Thank you.
What is the question you'd like to ask me, Andrew?
I'd just like your thoughts on whether you feel that there are distinct phenotypes of lung injury in
Yes.
COVID.
Well,
and if so, what are your thoughts?
Well, this is, coincidence does exist, isn't it? So I'll tell you, this very morning, we had an intensive discussion, which we do every week with the intensive care doctors and the doctors who are from infectiology and all departments. And there was a pathologist who had done the first autopsies, and that was done in Erasmus, Rotterdam, and they had exactly the same idea. They brought exactly the same idea, but there was a bit of a confusion whether this is an autopsy finding or whether this is a clinical finding. And I put this question twice in the group this morning, but there was a bit uncertainty. So I'm very curious from Dave to hear, because if it's really two phenotypes, which for me is a bit difficult because as an internist, I always learn my pupils, and I always learn that patients only have one disease at a time. So two phenotypes is a bit difficult from one disease, but if it is so that there is some more pulmonology phenotype or a pneumonitis phenotype and a more cytokine storm-based phenotype with thrombosis, this could open a way for dissecting treatment, because that everybody will agree at the intensive care unit, this is one of the most vexing challenges, what to choose for these patients. And attach that very short, Andrew, than I. And it's just so depending on in what phase they are, when they come to the intensive care, how long they are there. We had a graph of not so many patients in Spain, but there are A, B, and C patients. A patients fare very well within 2 or 3 days, and they don't need much more than ventilation. B patients are a bit longer, and the C patients are the most challenging, because that's a landscape of mountains. They go up and down in their ventilation, in their problems, and they're so challenging what to choose. So if we can learn from autopsies, I don't know, because I'm always a bit vigilant to learn from autopsies, that there are these phenotypes we might dissect and give more specific treatment. That's what I learned this morning, and I'm very curious of David to know his opinion in this, being a pulmonologist.
David, if you could respond.
Well, I have a feeling because we were about to collapse with so many patients, and I didn't have any time to digest the data and to analyze these data. But I can tell you that my feeling is that there is a group of patients with a benign disease, just coronavirus pneumonia, and these patients usually, at least in our practice, do very similar to what we were used to seeing patients with flu. Even I will say that these patients do very well with symptomatic treatment. No need for chloroquine, or no need for lopinavir, or for azithromycin, or whatever. There is another group in which there is a very high inflammation, if I could say that, probably with this cytokine storm, and these patients are behave very similar to what we used to see in patients with idiopathic pulmonary fibrosis. Some of our patients with idiopathic pulmonary fibrosis do very well with anti-inflammatory drugs, but most of these patients progress to very severe fibrosis. It is very difficult to ventilate these patients, and these are the patients who are dying with COVID-19. This is at least our experience.
Yeah, I mean, it does seem to be that this is a multi-system disorder, and people focus a lot on the chest X-ray findings and CT findings. You've mentioned thrombosis in the small blood vessels, which brings us nicely on to Beverly. So Beverly Hunt is a professor of hematology and thrombosis at St. Thomas's Hospital. She's had some famous patients there recently. I'm sure you can't talk about that, but that's the place where our Prime Minister was recently admitted to and healed by the brilliance of the St. Thomas's team. So Beverly, there's been a lot of discussion about whether this is a condition that causes pulmonary embolism or a condition that causes thrombosis. And while it might seem at first glance not such a distinction, it probably is in this case. Do you have any comments on it?
I've got my slides.
Wonderful. Let's see them.
And I'm going to cover everything that you've just been talking about. So it's really my view of thrombosis and thromboprophylaxis.
Yes.
So I have to advance my slides on some other piece of equipment. Let's have a look. Go. That's very odd. There we go. So my next slide. Do you think I could have my next slide, Nicholas? There we go. So just to remind you that we've only been following COVID for a limited period of time. I think it's 110 days since the WHO notified us, and it's everywhere. And the only places where it isn't is in the British Antarctica, and they've hidden themselves away, and the Polynesian Islands. Next slide. So what I wanted to just do was to look at COVID holistically, not just look at the hemostasis in isolation. I want to try to adhere to hard evidence rather than the beliefs and the perceptions that are around, and to recognize that many of the publications about COVID are very poor quality. And it seems if you put COVID in the title of your paper, it will get accepted without any peer review, and we have to stop this practice. And the other recognition is that it's really hard looking after COVID. And there has been a lot of criticism that a lot of doctors have used a lot of anticoagulation, but really they're doing that because they want to help their patients, and the evidence isn't there yet. Next slide. So just to remind you of the concepts around hemostasis and sepsis, inflammation and hypoxia. So really coagulation has evolved as a factor system of the immune response. So we really talk about immunothrombosis. And the whole point of fibrin in the premature of the very small organisms is to lay down fibrin around bacteria to entrap them and to prevent them disseminating. And the next point to say is that if you get severe inflammation, the endpoint is thrombosis. And to remind you all, when you see pulmonary vasculitis or you manage someone with Behçet's, you treat them with anti-inflammatories. You don't give them anticoagulants. It doesn't affect how the disease responds. And lastly, this is a disease with hypoxia. And hypoxia through the hypoxia-inducible transcription factor will lead to a profound prothrombotic state. There are binding sites on the promoter regions of a number of prothrombotic genes. Next slide. So we are admitting patients because they're hypoxic, and this is the traffic lights that we use at Guy's and St. Thomas's, including the Prime Minister. He was put through this. The more hypoxic you are, the more likely you are to be ventilated. And there's a cutoff where if you're very hypoxic, then you will automatically be intubated in the emergency department. Next slide. So if you look at the histopathology of the lung, and I've read all the papers that there are, the Chinese and the New Orleans papers, what do we find? We find profound inflammation, the classic changes of acute lung injury. And so you get fibrin deposition in the extracellular spaces, and there's a hell of a lot of cells there trying to deal with this. And what's surprising, I think, about COVID is there's so many macrophages there. You also see quite a lot of hemorrhage scattered, and then that is in a different place from where there is fibrin deposition. So there's been that discussion that acute lung injury, we know a lot about acute lung injury, although not in COVID, but we know if it happens, we've got profound inflammation due to a cytokine storm. Everything gets activated, the macrophages, the endothelial cells, and presumably the platelets. And we've got just soup of cytokines, IL-1, IL-6, IL-8, and TNF-alpha. And these will result in a prothrombotic state, particularly IL-6, because it's responsible for the acute phase proteins, and it will push up the ferritin to the amazing levels we see. We see CRPs 200, 300, D-dimers 8 to 12 times normal levels, and fibrinogens. In the last couple of weeks, I've seen a fibrinogen as high as 14 grams per liter in somebody who's very, very sick. And you know that the normal fibrinogen is 2 to 4 grams. Next slide, please. So when you look further at the histopathology, you're finding all these microvascular clots in the lung, but you're not really finding anything microvascular in any other organ. So to me, next slide, please. This means that we have got immunothrombosis actually within the lung. This is not a DIC, as the Chinese originally said. Next slide, please. And so I thought it was primarily not a thrombotic process, but we have this very poorly reviewed paper in the New England Journal of Medicine last week. I don't know who reviewed this, or probably nobody, but they said that antiphospholipid antibodies were associated with thrombosis and described 3 patients. And actually, the patients hadn't been checked twice for the levels of the antibodies. And they'd only checked them once, and they had IgA antibodies and anti-beta-2 glycoprotein 1 antibodies, and they didn't check or tell us about the titers of the antibodies either. And lots of people have low titers of antibodies, so you can't say they have APL antibodies. And then the other issue was these 3 patients had lots of reasons to have thrombosis. They all had diabetes, cancer, previous stroke, hypertension. So if you put someone like that in the emergency or situation or in critical care, you are expecting them to have recurrent stroke. We know recurrent stroke occurs in acute infections. Next slide, please. So the other thing to say is everyone has focused on the very high levels of D-dimers that are seen in the COVID patients. And there's this neat study from Wuhan where they looked at patients the year before who had viral pneumonia that wasn't due to COVID, and they showed they got the same high level of D-dimer. So this isn't unique to COVID, it's just we haven't really looked before. Next slide, please. So the question is, why are the D-dimer levels high? Now, the assumption has been made that what's going on is we've got clot being formed, and when you form clot, you produce thrombin, and that stimulates tissue plasminogen activator release from the endothelium. But actually, no one's looked at that. Next slide, please. And there's a whole literature about the fact that the lung itself can produce urokinase type plasminogen activator, or just urokinase is what everyone calls it. So the pulmonary pneumocytes can produce urokinase, and we know from a SARS mouse model that if you give varying doses of SARS to mice, they will produce more urokinase with a bigger dose. So it's a response to having an infection, but we don't clearly understand this pathway. Next slide, please. And the other thing is, just to remind you that the lung tissue is full of macrophages, and macrophages produce urokinase, and they've also got an acute system whereby they can grab passing fibrin, pull it into their lysosome, and break down the fibrin with cathepsin. So they're not even using plasmin, they're using their own different system. So there's lots of reasons why, if you have acute lung inflammation with tissue full of macrophages, that D-dimer levels might be raised in the plasma. Next slide, please. So for me, this is how I think about COVID. We know that it binds to the ACE2 receptor on the pulmonary epithelium, and also the receptors on the endothelium and on macrophages, and the renal endothelium as well. And there's some literature I was reading from this week's Lancet to suggest it's also on the small intestine endothelium. And so for a poor minority, 20% of patients, instead of having a relatively mild illness, they're going to go on to get COVID pneumonia with this massive inflammatory response. And looking at, we've had 400 patients who we've ventilated. They all have this inflammatory response. I haven't found any who don't have incredibly high ferritins, D-dimers, and CRPs. And that state leads to a prothrombotic state. Next slide, please. The characteristics of those patients, to me, suggest they all have pre-existing inflammatory states because they're mainly male, they're quite often obese. We know that in the UK, 75% of men aged 62, which is the average age of COVID in the UK, are obese, or they might have atherosclerosis or diabetes. Next slide, please. Just to remind you that states like obesity really do cause inflammation, and in obesity, the adipocytes, they chuck out cytokines in a very similar fashion to inflamed lung, but not quite such high levels. Next slide, please. So looking at VTE in critically ill patients, just to remind you, we expect VTE, hospital-associated VTE in critical care. But actually, looking at the current data, I'm not quite sure, and no one really knows what the current rates are in non-COVID patients. When you look back to the studies, there's one the first was in 82. They looked with radio-labeled fibrinogen, and they found that 29% of the patients had evidence of DVT. Then some of the medical studies at the turn of the century found rates of 15% in the placebo arm. And of course, sitting on intensive care, it's just the perfect suit to get a DVT. You're immobile, you're ill, you've got a pro-inflammatory state. Next slide, please. So we know that heparinoids help medical patients. We've got lots of studies done, randomized controlled studies where we've been shown that if you give low molecular weight heparin, you reduce the risk of venous thromboembolism by 50%. Next slide. And if we look specifically in critical care, with the critical care literature is pretty good. We've got 7,500 patients in RCTs, and if you give heparin in the standard dose, either low molecular weight or unfractionated, you'll get a response. But which is better? Actually, low molecular weight heparin, you've got a 50% further reduction in DVT and PE compared with unfractionated. So overall, you've got about a 50% reduction of VTE with low molecular weight heparin in critical care patients. Next slide, please. Just to remind you that we have entered the age of extended thromboprophylaxis. So low molecular weight heparin given to medical patients on discharge doesn't actually have a net benefit. You get some slight reduction in rate of VTE, but boy, do they bleed. So the net benefit's no good. But now with the DOACs, we now have Betrixaban licensed in the US, and Rivaroxaban just got a license recently from the APEX trial. They're not licensed in Europe because the European Medicine Agency felt that they weren't cost effective because you're giving another month's drug for a minor reduction in events, but they didn't really look at prothrombotic patients like the COVID patients. Next slide, please. And just to look at the criteria for extending prophylaxis that is the license in the States, you have to have certain risk factors, And the ones in the list include intensive care and those with D-dimers more than twice normal. So those are the COVID patients. Next slide, please. There you go. Just highlight it. Next slide. So looking at the COVID literature, we've got this paper from Tang. Now, what becomes very obvious as soon as you look at their literature is they don't routinely use thromboprophylaxis. So here they gave 22% of their patients heparin. We don't know what type, we don't know what dose, but there was a reduction in mortality and a reduction in coagulopathy. Next slide, please. Can we move on? Thank you. So looking at the more recent papers, so the paper by Kai I've mentioned, and then we've got 2 papers from the Netherlands. We've got Eric Klok's paper. He looked at 184 ICU COVID patients. It's a very quick turnaround paper. 3/4 of them are still in ICU when he's publishing the paper. He didn't, I think, give enough thromboprophylaxis. So he's using 2,850 in nadraparin. I think it should be 5,700. And he saw 25 PE. So that's a lot. But I want to point out to you that 7 was subsegmental. So that's about 31% is subsegmental. Moving on to the next one. This came out 2 days ago. I'm sorry, the slide's not very good. This is Saskia Middeldorp from Amsterdam, looking at 186 patients. They followed for 5 days in their critical care, and only 1/4 of them have not actually been discharged. They are giving 2 doses of nadraparin. If you're on the ward and you're a little bit mobile, you get nadraparin 2,800. If you're in ICU, you're getting nadraparin 5,700. Now, on my slide, I haven't got enough resolution to see the breakdown, but I know this paper very well because all of her PE was subsegmental or segmental. There were no large vessel PE. There were no saddle embolus or major arteries were not involved, and then there were a few DVT. Next slide, please. So I'm not quite clear yet what the current rates of VTE are in critical care, and so I'm not clear that there is a higher rate in COVID patients, but I think that we're heading towards the fact that there probably is. But I don't think that we're just seeing PE. I think we're seeing 2 things. I think we're seeing PE, but a lot of it is we're picking up the inflammation, the pulmonary inflammation, which has ended in microvascular thrombosis. And that when we say subsegmental PE or even segmental, if you look at that CTPA, you'll find that area has got quite a density around it, suggesting it's a place of high inflammation. Narayan Karunathan, who's hopefully on this call, is looking at that to see if we can get some way of trying to say radiologically, this looks like an endpoint of inflammation. So when we come to thromboprophylaxis, we really have very poor evidence. First of all, I'd say if we're using standard dose, you should use weight adjusted because these tend to be really large people. Often over 100 kilogram, and all the trials were done at the turn of the century when people were smaller. The average BMI then was about 25, and now in the UK it's 28.5. The question that everyone is asking and really moving on and not waiting for the answer is, would a higher dose of thromboprophylaxis be beneficial without increasing bleeding risk? Should we be adding in intermittent pneumatic compression? I think we should in intensive care because we know it's got equal benefit to low molecular weight heparin in the studies. Should we be giving extended thromboprophylaxis? And we're just trying to get a big trial going in the UK to look at that. But the thing that bugs me more than anything, is will the anticoagulation actually help if what we're seeing is subsegmental PE or rather immunothrombosis, surely we should be getting these patients to get anti-inflammatory or anti-cytokine treatment. Isn't that the group that would benefit most? Next slide, please. How do we manage fresh VTE? Well, when we started and we were fairly overwhelmed, we didn't have enough time to do CTPA. So if somebody went off and became more hypoxic, we would tend to treat them as a PE. And I think lots of people are doing that. Now we want to, the numbers are more controlled. We've only got 110 ventilated at the moment, and we've got spare capacity and critical in imaging. We would like to image everyone before they come to ITU because we suspect we're going to find quite a lot who have PA, and then we can give them full dose low molecular weight heparin at the right time and give the others a lower dose. If you've had a PE, then obviously these are highly provoked. So you'd only give 3 months anticoagulation, but none of us have got to the stage yet where we've given 3 months anticoagulation because it's such a new epidemic. Catheter-associated thrombosis, we're seeing a lot of that, and we'd be giving 6 weeks treatment according to standard guidance. Next slide, please. So for me, there's acute lung injury in COVID, and it's leading to changes on CTPA, which we're calling PE, but I really think we've got to start saying, actually, this might be immunothrombosis. I think D-dimers are coming directly from the lung, which is why when you look at the papers, their prognostic value, the higher your D-dimer, the more lung injury you've got, the more likely you are to die. We still need more data on background rates of VTE in COVID. We need to know about anticoagulation trials, and we need to think about this immunothrombosis. We have today opened up an arm in one of our big studies to use an anti-IL-6 antibody, and hopefully that might help. Next slide. This is my last slide, I think the next one. But that's just our what we tell people on intensive care. We've got a lot of redeployed doctors, and we make everything simple for them. Next slide, please. So I think that the future has to be the research. In the UK, our chief medical officer won't let us do research on COVID. It's very frustrating. He won't let us do any research until he's inspected it. And they're thinking back to the Ebola epidemic, where there were lots of small trials that came to very poor conclusions. And we've gone the other way in the UK, in that we can only put our patients on large platform studies. So recovery looks at those on the wards and tries out different treatments. And REMAP-CAP looks at the very sick ones in critical care. Managed to get an arm into REMAP-CAP so that they are going to compare standard anticoagulation with full dose. That's going to come out in a few weeks, and talking to them, and we're hoping that they'll open another arm just for anticoagulation for us to look at the ward patients with different doses of low molecular weight heparin. That's me done. Thank you.
Okay, thank you, Beverly. That's a real tour de force through the disease. You've talked about immunothrombosis being distinct from PE. Do you think that the clot we're seeing on these scans is a driver of deterioration? Do you think it's just part of a disease that is there and making a small contribution to their hypoxia and their eventual decline? Or do you think this is not a serious factor in what's happening to a lot of these patients?
Well, at medical school, I was always told that God gave us too much lung, and that you can manage on just half a lung. And what this microvascular thrombosis is doing, well, it's removing lung, isn't it? And I think we're all, Jerry's no doubt going to talk about this, a little bit worried about those who do recover after really severe COVID, about how much lung they might actually have left and whether they might get pulmonary hypertension later. I think it's a significant factor. We need to stop them from getting to this point, don't we? So that's why I think we need to go upstream, and the antivirals and the anti-inflammatories need to stop us having such profound inflammation that we get this problem. I don't think anticoagulants are going to do very much here. I mean, I manage Behçet's disease a lot, and that's a very similar scenario with profound inflammation. That does wonderfully well on the anti-IL-1s, and if you give anticoagulation, they're just carrying on having thrombosis, and they bleed as well. But time will tell, won't it?
Andrew, this is Narayan Karunathi here. I just wonder if I could come in just a little bit, just to sort of extend the conversation about the potential for this being two slightly different disease processes, perhaps. As Beverly's alluded to, we've started to look through our data of CT pulmonary angiograms that these patients have undergone. And as a lot of centers at the outset, we were quite overwhelmed. And so we were finding that it was really only the very sick patients were getting to having CTPAs. The situation slightly changed. It's become, there's more capacity. So we're trying to get to a situation where we image patients sooner. And clearly there are a large cohort of patients who have this very segmental, very peripheral, segmental, subsegmental involvement. But we are seeing a relatively significant proportion of patients with saddle pulmonary emboli, with perhaps not so much a lung parenchymal change as you would expect if if your hypothesis was that it was all propagation of in situ pulmonary thrombosis. So it sort of adds credence to the hypothesis that perhaps on the one hand you have an inflammatory process, on the other hand a prothrombotic state, which may be creating a situation where you're more likely to form your regular VTEs. Again, that's hypothesis, and I think we're very much focusing, as Beverly has alluded to, on the CT pulmonary angiogram. So hopefully give us a feel for possibly different patterns, and which may then help us guide treatment from there on.
That's great, Narayan. David, do you want to come in? I mean, I've seen two patterns of presentation where there's this widespread peripheral thrombus, and I have seen a few central life-threatening massive pulmonary embolisms. And I've seen not that much in between. But David, what's your experience in Spain?
Well, my feeling, most of the times we were able to diagnose very small clots. In fact, in March 2020, we ordered 35 CT scans because of suspicion of pulmonary embolism among COVID-19 patients, and the prevalence of pulmonary embolism, and most of these were segmental and lower. We didn't have any clot in the main pulmonary arteries. The prevalence was 44%. We diagnosed 15 patients with pulmonary embolism. But in my opinion is that we are seeing two different kinds of patients. Most of the clots that we are seeing in patients with COVID-19 are very small clots. I completely agree with Beverly that there is local thrombosis, and we are also seeing other patients that these patients will came to the emergency department because of pulmonary embolism, 2019, 2020, or 2018. And at the same time, these patients are COVID-19. So I think that we are seeing two different populations, those with small clots that might be driven because of COVID-19, and those with big clots that they are patients that are going to have venous thromboembolism, and they are also positive for coronavirus.
Yeah, Jerry, if I could come to you, Jerry Coghlan from the Royal Free. From our conversation, that's what we've seen. In your center, you've seen possibly patients who are with PE who happen to have COVID, and then a different pattern of patients who have COVID-associated thrombosis. Is that what you're seeing?
Yeah, I think that, as has been said, so most of the pulmonary emboli are small, either segmental or subsegmental, and are in the areas where one sees a lot of lung disease. But probably about a quarter of the pulmonary emboli we're seeing are either saddle or lobar, and certainly we've seen people with big dilated right ventricles, hemodynamic compromise. So I'm sure that there is a significant number where there is a prothrombotic status that is driving a true pulmonary embolism type situation as well. I think these patients are dehydrated on admission, Just one other thing is that we're seeing pulmonary emboli in people as they come in the door, not just in ITU.
Yeah, Beverly, if I could come back to you about your comment about getting upstream. We're seeing a lot of people who are very sick on arrival with grossly abnormal CTs on arrival. And these are patients who describe 1 or 2 days of symptoms. They're suddenly very, very sick with very florid abnormalities. Do you think we can get upstream far enough to prevent the immunothrombosis, given how late some of these patients are presenting?
So, I mean, just coming back to the presentation, they averagely present between day 7 to 10, don't they, with respiratory problems. And one of the issues is that although they're profoundly hypoxic, they don't notice it because they don't have hypercapnia. So they're presenting late because they don't feel breathless. So that's one issue. But the other issue is, yes, they need to start treating people when they go down with the symptoms, I would say. But as we don't have any effective treatment, then it's a bit early to be doing that.
Yeah. Nick Murch from Throw Free, you're at the front door. Can you tell us what you're seeing in the ambulatory population, the ward-based population, in terms of VTE, so DVT, large volume central PE, and this peripheral thrombosis?
So I would, thanks for inviting me. I would hark back to the comments from Beverly and Jerry, in all honesty. There seems to be this peripheral, small, almost microthrombi. And then there does appear to be nothing really in the middle. And then patients coming in with large saddle embolus, which we are seeing a proportion of. I would hark back to Jerry's point about the fact these patients are often profoundly dehydrated before they when they come in. And often one of the things, we're all becoming experts in this disease that's only been around, or syndrome that's only been around for four months or so, and we're changing our practice. And originally we were running them quite dry, and now we're trying to get them euvolemic. Also, we've got to remember that they're self-isolating for 7 to 10 days at home. And often this is when they're getting unwell. I suspect people are not getting out, exerting themselves, probably not noticing hypoxia because they're not pushing themselves as much as they would normally. And we've got a perfect storm with that immunological response going on for them to get thrombi. We're not finding a huge amount of DVT, in all honesty, from experience from colleagues across the patch, but we are finding quite large volume PEs. We're finding people are clotting off the renal circuits much more quickly, which I'm sure Alan will touch upon. And we're finding that generally they're just prothrombotic. So I think we aren't seeing many sort of medium-sized PEs. We're seeing large PEs, and I suspect all of them have got small microthrombi.
Andrew, can I just make a very quick point?
Yes, Alan, go ahead. Yeah.
There's a similarity here to, and I'm not saying it's exactly the same, but there's a similarity here to people who have systemic vasculitis. They have an endothelialitis, which has been described in these patients. And patients with vasculitis have about 15% of patients with acute vasculitis will have large clots. And we know that, as Beverly said, in those situations, we will treat the clots with anticoagulation, but the underlying condition is treated by immunotherapy. And, Ernest Goodpasture, his original description of anti-GBM disease, which he got wrong, which was actually a vasculitis, he thought was due to influenza. And there is a lot of things that are very, very similar here in patients who have acute small vessel vasculitis, who have thrombocythemia, elevated CRPs, very strong pro-inflammatory drivers. And there is an association in some of those patients with an acute clot. And I think what we're seeing here maybe is that sort of endothelialitis in the lung, possibly in some other vascular beds, as Beverly's alluded to, in some of the other organs that have been looked at post-mortems. But it's a very similar phenotype, I think.
Beverly, would you like to come back?
Yes, with that amount of cytokine release, you'd expect endothelial cell activation in most of the endothelium in the body. There are other words for it, aren't there? Systemic inflammatory response syndrome, that's what we're seeing. But there are areas that are particularly hurt, and those are the ones where I suspect that COVID can get in, and that's pulmonary, renal, and then this emerging thing that they're getting small vessel disease, and we've had to do laparotomies on a few of the patients, and they have had duodenal microinfarct. So you sort of think, and looking at the histopathology report in the Lancet yesterday, it said that there were inclusion bodies of virus in the small intestine endothelium.
Yeah.
So it really interesting, but scary.
Menno, if you're still there, we had a discussion earlier about the low molecular heparin prophylaxis that's occurring in your country and whether patients are getting enough. Do you have any thoughts on that? Why are the dosings as they are?
I think it's a valid point. We have always been very obedient. You hear me? Oh,
yes, great. Yeah.
So thanks for Beverly's talk. It's very good. I'm just showing here now in the garden. We have been always obedient and following the Padua score, although we never really believed that was validated well enough. And then we soon found out that if you stick to that a lot of patients wouldn't get it. So we changed it to the standard prophylaxis. And as Beverly says, but I think it's a bit knowledge on the way that it may now be too low. And if you go from too low to a bit less low, then you go to a higher, and then you will end up in giving them therapeutic anticoagulation whatsoever. I would make a distinction, which I think is a bit not shed light on, and that is the gross difference between the VTE incidence in the ward patients with COVID and the ICU patients. I think I haven't read full the details of Saskia's paper yet, but I think she had a mixed population of ward and ICU. We have nearly finished now an analysis of ward patients of the same hospitals in the ICU, and we're gonna soon submit that. But I can tell you there is this difference. So, and this I think is key to how you would attack these patients, either with anti-inflammatory agents and anticoagulation, or a combination ideally. And the fact is whether you will do it at what time point. So there's a lot of fuss around who you should attack with full anticoagulation. My short point is, as soon as patients come into the ICU, in their bag is a highly inflammatory state, and with that comes thrombosis whatsoever. If you call it immunothrombosis, fine, but it's not only immunothrombosis. I believe that looking at our data at least, and we have now, by the way, increased and enriched our data of the publication of IRIC, because we have gone back to the ICUs of all hospitals and seen a lot more. So for instance, very short, in our hospital, we were very reluctant to do CTPA. Now we do it in every patient. Nearly all patients have PE, if they are in the ICU, believe it or not. Erasmus in Rotterdam, the same. So it's very tempting to give these patients anticoagulant treatment, because if you're a doctor and you see a clot, you want to treat it. But I agree with Beverly that it may not be.
It's not the answer, is it? I mean, I think that you have to give it.
Let me finish, please, Bev.
Yeah.
It's not the answer, because they need more of these patients, and then becomes a very practical problem. How do you evaluate this? Because randomized trials, okay, but you have a a discussion with the people who believe in the antiviral and the anti-inflammatory. So it's very difficult to evaluate ICU patients at this stage. You know, you can't pick only anticoagulation. I fully agree with the former discussant. If you do that, it's too simplistic. But how would you start?
So we've started. So that's the joy of the platform studies. So that these are, we've got Recovery and REMAP-CAP. They were designed for pandemics. And so they're platforms. They use Bayesian analysis, and they can enter huge numbers of patients. So we've entered 6,000 patients into REMAP-CAP since it started a month ago in the UK. And so the data all goes in, and they will be able to look at the different effects of the agents and whether they work together. So it is really exciting that we do have these big platform studies.
Yeah, but I'm afraid, what is the methodology? Because platform is fine, but we need very strict protocols. And the challenging thing is that as soon as you start saying that you want to randomize anticoagulation with high dose prophylaxis, another one will say, no, anti-inflammatory is much more important. So how to mix this in a way that you end up with one group having at least both of these.
So it's a pragmatic study. So that is going to happen. There will be people who will have anticoagulation on its own or anti-inflammatory on their own with standard thromboprophylaxis, and some will have both together. And, you know, it will happen because we seem to have so many patients and it's been very well thought out.
Beverly, if you don't mind, I'm going to just turn the conversation a little bit towards what we do about patients who have the more central large volume saddle pulmonary embolisms and how we're managing them, what we're doing with them. So we have Lauren Bonello on the call. Lauren, if you wouldn't mind unmuting yourself and just telling us about your experience of very sick patients, large volume pulmonary embolism, what you're seeing, how often you're seeing it, and what you're doing about it.
Yeah, so I have to admit that I agree with the previous presenter, and in fact, in the ICU, we see a lot of patients having large pulmonary embolism, and it's been a struggle in my hospital because most of the time those patients are too sick to go for the CT, and transthoracic echo is used to confirm the diagnosis. The patients are unstable, and it's been a great challenge to be able to treat them as they have both respiratory insufficiency and hemodynamic impairment. So it's been a struggle, and I do believe that there is a lot of patients dying from COVID because of pulmonary embolism. So shall I give my few slides now?
Yeah, please do. Go ahead.
Okay. So maybe you can put the slides on. So we've been working in France during the last months on expert consensus on pulmonary embolism and the reperfusion therapy. And so we've been discussing with surgeon, vascular surgeon, with angiologist, with interventional cardiologist, general cardiologist. And so we end up with a consensus. And this is what we are applying right now. It's been very timely. So in massive PE, what is our reperfusion strategy? Of course, systemic thrombolysis is used mainly this patient, but sometimes the hemodynamic impairment requires the use of ECMO, arteriovenous ECMO, which, as you all know, ensure both heart-lung shunt to ensure oxygenation and hemodynamic stabilization. So in what patient are we using ECMO? We are using it when there is a failed thrombolysis in a patient that remains unstable following standard thrombolysis, but also for patients who have hemodynamic instability and cannot get IV thrombolysis because they have a bleeding issue. And as you said before, this is sometimes the case in those COVID patients that bleed on some vascular beds, but they have also a large pulmonary embolism. So we are using ECMO in some of these patients. And of course, as you know, and as it has been suggested by the recent ESC guidelines, if you put the ECMO, then you should be using reperfusion therapy in addition. So most of the time, of course, is the IV thrombolysis. But if it failed, or if the patient has bleeding diastasis, well, then we are using also devices like the ECOS device, which is in our PERT team. And so we've been using the ECOS in addition to ECMO in these patients. And we've been using that in 2 of these patients. So maybe I can describe the first patient. This is the next slide. So that was a 40-year-old man who had severe pneumonia, COVID, of course. He had ARDS and was in ventral decubitus because they had a lot of issue to have to stabilize the patient from his lung insufficiency. On the 8th day, and despite thrombophylaxis, which is very current in the ICU in my hospital, for all patients that have a D-dimer above 1 is getting thromboprophylaxis. Then this patient went into hemodynamic instability, and he had a TEE, which show a large thrombus in the main pulmonary artery trunk. So it was decided for this young patient who had no bleeding diastasis to go and perform systemic thrombolysis. He was stabilized also with norepinephrine because he had a low artery pressure and a very large RV and depressed LV function because of the compression due to the RV. So after 3 hours, he was still very unstable, and it was very difficult for the ICU team to maintain the hemodynamics. So it was decided to implant an arteriovenous ECMO, and also because there remain large thrombus on the main pulmonary artery trunk going to both lungs to perform ultrasound-directed thrombolysis. So this is what you will be shown on the next slide with a few pictures. Of course, it was not very difficult. There was no proximal venous thrombosis, so it was possible to puncture the left femoral vein and to come up through the right ventricle to the pulmonary artery. On the left side, we've seen no large thrombus. It was all disseminated in the segmental arteries. But as you can see on the right side, there was still large thrombus on the proximal trunk. So we had the ecosystem placed for 24 hours. And thanks to ECMO and to all these thrombolysis procedure, both the systemic and then the ultrasound-directed thrombolysis, this patient could be stabilized 24 hours after the procedure, and the ECMO was weaned which I think 1 day after. So he is now stabilized from an hemodynamic standpoint. This was done last week, but he's still in ARDS and is still intubated. So very severe pneumonia. The RV is still dysfunctional, of course, but now he doesn't need any more ECMO. So I think this, in these very extreme cases, sometimes you have to, to get extreme treatment, such as ECMO and reperfusion therapy in addition to ECMO. So this is just what I just say, 24 hours of ultrasound-directed thrombolysis, and it could be weaned from the ECMO. He had no bleeding, but as I told you, this patient, now it's been 16 days since he was admitted in the ICU, 8 days since he had the procedure is still in ARDS and requiring artificial ventilation.
So there's no quick fix here, is there? You've got someone with very advanced COVID disease and also massive pulmonary embolism. It's not like you're able to turn these people around quickly with interventions. You're just stopping the slide and hoping you can get them through it. Yeah, we've also got Nima Hatam on the call. Nima, are you still there?
Yeah, I'm here. Hi.
Yeah, you've got very extensive experience of ECMO support of these patients. Tell us a little bit about it.
Yeah, I'm working in the University Hospital in Aachen, which is the region in Western Germany where the Corona crisis started, in the town of Heinsberg and this vicinity. So we had a lot of COVID patients in ARDS who were not being able to stabilize with the standard ARDS treatment, which our center, our anesthetists and ICU people have a lot of experience with. So at the first beginning, we had to implant especially VV ECMOs, but then escalate them to VA ECMOs. So at the moment, we have a total number of over 15 ECMOs used. At the moment, it's 6 running. There were around 4 people that were weaned off ECMO. And 2 of these patients had actually concomitant large PE. But before I met these patients, I had to do thoracoscopy, an emergency thoracoscopy, another COVID patient due to a malpuncture. And when I saw the surface of the visceral pleura, I was really shocked seeing major bleedings under the pleural surface, just like a pneumonia. Because before I saw this patient, I was happy to do aqueous thrombolysis or even systemic thrombolysis on PE. But after seeing that, and me and my colleagues got a bit afraid using reperfusion strategies with this cohort of patients. But we used systemic low-dose thrombolysis in 2 of these PE patients, which were in full flow ECMO, VA ECMO. The thrombus was reduced. There was no major bleeding, but right heart function did not recover, as our previous talkers have said. But I think because of the very invasive way of ventilating these patients, you have very high interthoracic pressures and producing venous congestion in the body as well, and in making right heart dysfunction. So we have many factors leading to right heart dysfunction. I don't know if it was the strategy of our hospital with the very high airway pressures, but most of these patients received VV ECMO, so the right ventricle was more or less sufficient, the function. But still, I believe that because I do many of these echocardiograms, you see enlarged and hypokinetic right ventricles. I don't know if you can agree with that. Maybe Nick and Andrew, you have a lot of experience with echocardiography in the right ventricle.
Yeah, we've seen a lot of this. I've seen echocardiograms where I'm absolutely convinced that if the patient goes to the scanner, they're going to have a massive central pulmonary embolism. And yet we have not seen in some of these patients, we have in others, but we've seen 2 echocardiograms that look identical. Huge right ventricular dilatation, the lung axis functions right down, you have dyskinesis at the apex, septal, the septum's going the wrong way. We take them to the scanner, we set up in the cath lab in order to treat them invasively if we have to. And then we see peripheral thrombus. We're not seeing central in some of them. And yet in others, with exactly the same echoes, we're seeing gigantic clot burden in the main pulmonary artery. So we have 2 colleagues from Italy, sort of ground zero of the experience of COVID. We have Dr. Antonio Rampoldi and Dr. Mario Galli. And I just wonder if it's possible to pull them across. I think you have to raise your hand if you know how to do that on the Zoom function. If those 2 doctors are still on here, I'd like to hear a little bit about what they see and in Italy. Yeah, great. So Nicholas, if you wouldn't mind pulling across Dr. Rampoldi, he's raised his hand there. And can you unmute yourself? Is that possible?
Antonio Rampoldi from Niguarda Hospital, Milan.
Yeah.
We have now the situation in North Italy is becoming better, but we have a lot of patients and we have a lot of pulmonary embolism. And above all, we observe segmental, but also pulmonary embolism of the main trunk of the pulmonary artery. So our protocol for this type of patient is using always anticoagulation, low wave heparin, and in case of deterioration of hemodynamic function, ECMO and also local thrombolysis. We have one cases, we use one case of proximal embolism. We solve the problem with echoes, with good result.
Well, I think we're going to hear.
Do you mind if I just comment on that? I think what was just been described is almost certainly our experience too, and the crux of the matter really is, as you described, figuring out if the right ventricular dysfunction and the cause for that. And our experience, and certainly our recent experience, is exactly that. That in the cohort of patients who appear to present with saddle PEs, who also happen to have COVID, I guess, when you find right ventricular dysfunction, those are the patients, if we are aggressive about treating with reperfusion therapies early, in our very small experience to date, we've seen very good response, and we've got patients off, completely off oxygen therapies within 24 hours by adopting that strategy. So the cohort of patients that we would consider very definitely for catheter-directed thrombolysis, and I must admit, and we've only really targeted those patients. The response seems to be good. So in terms of case selection, those patients who present with not so bad COVID peripherally but have saddle PEs, we've been very aggressive about getting them and treating them early with CDT.
Well, perhaps we could now go to Jerry Coughlin, who's got some cases, and it'll really follow up from that point. Jerry has some slides just to summarize some of the sicker patients he's seen with both COVID and pulmonary embolism. And again, it's this question: have they got COVID-related thrombosis, or have they got PE with COVID? So, Jerry, if you'd like to tell us a bit about your experience.
Yep, very happy. Do you want to bring up the slides there? Yeah, if you can move on to the next one there. As has been said time and time again here, there's multiple things going on here. So we assumed in the beginning that this was all going to be microvascular inflammatory disease, but there was a lot of CTPAs being done. And what we noted was that for our normal population, when CTPAs are done, 1 in 10 show pulmonary emboli, whereas with the COVID patients, about 50%. But that said, you could look at it the other way around. This only represents 5% of the COVID patients who were admitted over a 2-week period that ended up having CTPAs. But I think there are a couple of things that are sort of worth pointing out. They had 8 patients who were ventilated, but there were 15 that were within 24 hours of admission. So I'd say that it's not just the ITU patients we need to look at here. And of those patients that had CTPA within 24 hours admission, 7 had pulmonary emboli, and 3 of those were either lobar or main PAs. So there's substantial pulmonary emboli. The other interesting thing is that if you just look at PEs, it doesn't predict mortality in that population looked at over a period of 10 days. But if you looked at the right ventricle, it did. So patients who had large right ventricles did badly. And that probably means that there's a vascular problem or an afterload problem, which may or may not be related to the volume of thrombotic disease. There could obviously be a vasculopathy in these patients because of the inflammatory condition they're dealing with, or it could be hypoxia or various other things. So I think the right ventricle is right. That's where the key to telling us that these people are going to do badly is. You want to move on to the next one? Thank you. So here are 4 patients that we've done ECOS. So there's a 5th one on the ward that we're going to do shortly. And just to have a look at them briefly, the first one we were sort of offered was a 30-year-old man who was quite hypoxic, dilated right ventricle, saddle pulmonary embolism, and clean lungs. So we felt, well, that's fairly straightforward. He'd be done under normal circumstances. The fact that he was COVID positive didn't really bother us one way or the other. But what was impressive was the improvement in oxygenation in 24 hours in this gentleman. The second one I was a bit more dubious about because he was in ITU. He had developed severe hypotension, was on inotropes, he had extensive consolidation, but the feeling was that he was going to die if we didn't do something about him. And he had a saddle pulmonary embolism, a huge right ventricle. And again, a very impressive improvement in his oxygenation in 24 hours after ECOS. Subsequently, 10 days on, he's now tracheostomied, his lungs are beginning to improve, and his oxygenation remains similar to this level. So I was impressed that we didn't cause that much bleeding in this gentleman. Third gentleman, again, came in with multifocal ground glass shadowing, but you could have looked and said, are these lung infarcts or what are they? But eventually it was decided that was more COVID type things. He had, again, big main pulmonary arteries that were completely occluded on the left, had some flow on the right, dilated right ventricle. He intriguingly had to receive 4 liters of fluid on arrival in A&E, and he was straight from A&E. His blood pressure was still 85 on inotropes. He had a PA saturation of 34. So he was really quite sick. And again, a very good, impressive response. Now, he intrigues me because he did very well. He sort of had ischemic hepatitis and all the bits that go with being very sick. Got up and about, was walking around the ward on full dose tinzaparin. This morning, he was due to be pushed onto rivaroxaban, and he suddenly developed acute breathlessness again and collapsed and died this morning. So despite full anticoagulation and having had treatment, this guy obviously remained very prothrombotic. So there's, I think, more going on than we'd like. And the last chap is, you could sort of argue whether or not we should have done him a little bit, multifocal consolidation, big pulmonary embolism, and he was just persistently tachycardic, persistently on oxygen, and because he wasn't getting better, we did him, and again, a very nice improvement in his oxygenation. So this is more of an improvement in oxygenation than I'm normally used to seeing with ECOS, and it just raises a vague question in my mind that whether TPA is actually doing a little bit more here. If you give it in low dose, are we actually improving some of the peripheral perfusion? I appreciate there's no evidence base for that at this stage. And then finally, if we go on to the next slide, this is the before and after CTs on 2 of these gentlemen. So this is the young fellow that died this morning. You can see this huge dilated right atrium, huge dilated right ventricle, underfilled left ventricle, no perfusion of the left lung. He did bleed a bit into his right lung, but he survived that bit, okay? See the much improved perfusion of the left lung. And again, the right ventricle may not have changed, but the left ventricle is now filling, which is the difference. So the ratio has changed. This is the other gentleman from IT, sorry, he's not the IT gentleman. Again, you can see that the improvement in flow to the right front lobe, anterior aspect of the right lower lobe there, and the improved perfusion to the left lower lobe here. And again, his right ventricle, left ventricle was filling afterwards, but it's not shown in these pictures. So I think the right ventricle doesn't change dramatically, but you do improve perfusion to the left ventricle. So the RV-LV ratio does change in these patients. And it doesn't, when I started looking at these patients, I was worried about systemic thrombolysis, but I was also worried about ECOS because I felt these patients would bleed, but we haven't seen much of that trouble, much trouble with that. We do appear to be getting away with it for the moment rather than having a solid evidence base.
That's great. Marianne, is that your experience as well? You're seeing early response to thrombolytic-based therapies, or?
Yeah, again, our experience, I think very similar to Jerry, is we're treating the cohort of patients who have PE and sort of not too bad, sort of lung inflammatory change. Those patients respond extremely well. We've had a couple of patients who've been at the other extreme, who've been, on ITU for a couple of weeks, have got, pretty awful looking lung parenchyma, who have, had right ventricular dysfunction and large volume thrombus, and the response in those cases haven't been quite so dramatic. So it's sort of, the response we're seeing in certain select cohort of patients is extremely good. In others, it helps a little bit, but they still end up being in a respiratory failure and ventilator dependent. So it's very much along the lines of what Jerry's been described. Yes, absolutely.
Yeah, I'm just going to talk to David in a minute about how he's handling these. If Robin Conliffe is still on the call, can he put his hand up in the Zoom function, and then we'll move him across to panelists, because I'd like to hear what he's doing with these large volume Ps. So David, how are you handling them? I know you come from a slightly different perspective on what to do with large volume central thrombus, perhaps one or two people on the call. How are you doing?
I think that the bottom line is that we should manage these patients with severe P. We can use this terminology the same way as for patients that are coronavirus negative. So guidelines tell us that we should use reperfusion for patients with high-risk pulmonary embolism, with hemodynamically unstable pulmonary embolism, and we should do the same for patients with COVID-19 and severe pulmonary embolism. My only particular comment for these patients is that we have to be very sure that hemodynamic instability is driven by severe pulmonary embolism and not by COVID-19 itself. And in this way, I think that echocardiography is very important, is mandatory before deciding or indicating these advanced reperfusion therapies. If you perform the echo and there is no severe right ventricular dysfunction, then I think it is not very cautious to put these patients in the risk of reperfusion therapies with a very high risk of bleeding.
Andrew, would you mind if I just if I could follow that with a slight comment to David? So I guess do you buy into this hypothesis that there are potentially two slightly separate pathologies going on? One where you have immunothrombosis and in situ pulmonary thrombosis, and a second cohort who have Ps, or would you see all P thrombus in pulmonary arteries as pulmonary emboli and treat them all the same?
I think it is the former. There are two different types of patients, those with local thrombosis associated with COVID-19, and if I can put it this way, those with pulmonary embolism and associated COVID-19.
Yeah, and I think we're all seeing that, and we're seeing grossly dysfunctional right ventricles that don't seem to recover with anything. And if you don't have an acute large volume central pulmonary embolism and you have these huge dysfunctional right ventricles, they're dying. And we don't seem to be able to turn them around. And that's one of the reasons I wanted to come back to Nima. Nima, you're putting a lot of patients on ECMO. That is something we don't have easy to access to in some parts of the world. Have you characterized the right ventricles of the patients who are going on to ECMO? Is that the reason they're needing VA ECMO support, failing right ventricle, or is it something else?
Mainly it's the failing right ventricle. We did a little analysis of 50 COVID patients where 24 of them were in RDS and the 26 in non-RDS. And of these 24 RDS patients, 33% had to be put on ECMO, initially VV ECMO, with one exception that was already in right heart failure. But a couple of these patients developed right heart failure, but what we didn't see actually is which is described in the literature, is the failing of the left ventricle due to concomitant myocarditis. So we have an interdisciplinary discussion why these right ventricles are failing, and I think it's multilateral. You have your hypoxia, you have pulmonary embolism in these patients as well, even though it's only in the subsegmental regions, and it's very hard to estimate pulmonary vascular resistance with echo when they're on VV ECMO, because of course the hemodynamics are a bit off. And then you have these very high interthoracic pressures, with a high PEEP, and I think that especially because the median age of our patients was 66 years of age, that these ventricles cannot tolerate this volume and the preload of a lot of volume and the afterload with these high interthoracic pressures. So I really can't tell you. This is just a thing we have consented on, that it might be the combination of all these things, but we luckily didn't have to put in VA ECMOs primarily in a lot of patients.
Okay. Laurent, and you've been using ECMO in some of these very sick patients. If you see right heart failure without central pulmonary embolism, what's happening to these patients?
Well, I totally agree. It's very difficult to know, and it's probably multifactorial. Probably the lung disease is the main cause of the RV dysfunction, but really we don't know, and we're using ECMO, but it's not very efficient when you have already very dysfunctional RV. That's for sure.
Especially when it's been going on for a long time. Sorry, Jerry, because we have patients. We got patients admitted 5 or 7 days in the small hospital ICU. Until then, they called us the ECMO team, actually, when things were going against the wall. I mean, there's one patient, 67 years old. We have weaned him off ECMO, but he's still tachycardic without significant pulmonary embolism, but his right ventricle doesn't look good. It's just as you said, Andrew. I mean, he's off ECMO, he has very low inotropic support, but still this right ventricle, it looks like like a CTEPH ventricle at the beginning, you know, to be very...
Jerry, is that what you're seeing as well?
Yeah, I mean, one of the things to say is we do measure the pressures in our patients, and the pressures are quite substantial. One of those guys had a PA pressure of 78, which is pretty impressive for an acute pulmonary embolism. The other thing we're seeing a fair bit of is in the coronaries. You know, these patients do present with what appears to be heart attacks, and we're seeing a lot of poor perfusion of the heart. So you may have thrombus proximally, but you have no clearance distally. So I wouldn't be surprised if there's microvascular involvement in the heart as well, and that might be helping your right ventricle.
Mm-hmm.
Yeah, I mean, what we haven't seen is this rash of left ventricular failure that we saw on Twitter coming out of China and northern Italy.
We've seen virtually no myocarditis.
Yeah, left-sided, we haven't seen anything. Has anybody seen that? Would anyone like to comment on that? Because that hasn't been our experience. Antonio?
We haven't. We did biopsies as well, and we haven't, we couldn't show myocarditis.
No. Okay, well, that's interesting. Right, we're running out of time. I'd just like to call on Michael Jaffe, who is coming from America, where there's slightly at a different time point disease in some parts of America. Michael, what's your experience at the moment?
Fascinating, Professor. Thank you. And thanks to everybody. I've learned a great deal from this. And it's a rare opportunity. We're all facing the same thing, and we're only 4 months into this. In the US, I've spent the last week speaking to my colleagues from very hot zones in the heart of Manhattan to very, very low prevalence cases. And there's a huge difference. For example, in New York City, one of the big stories that's come out has not been this all this great discussion about venous thromboemboli, but in situ arterial thromboemboli. Cases such as mesenteric artery thrombosis, internal carotid artery thrombosis, renal artery and carotid artery thrombosis. And I agree completely with Professor Hunt. It's unclear what the underlying pathophysiology of those cases is, but something clearly is awry here, and it's beyond the obesity, dehydration, fever, etc. I would say that there's a broad disconnect in the United States physicians, largely due to disease prevalence, around in situ microvascular pulmonary thromboemboli and large central pulmonary emboli. And there are plenty of places, as you heard here, for example, in northern New Jersey, where the number of central pulmonary emboli causing catastrophic events requiring heroic salvage, including ECMO, some have done open pulmonary surgical embolectomy. It really has been amazing. I think the other thing that's very interesting, and I'd love if we have some time at another time to hear from this, is this concept that in the United States, particularly in very hot areas of the country, workers are unwilling to let patients go to the CT scanner who are COVID positive. And the concern about that is that the workers get additional exposure, but the need for complete terminal cleaning of the CT scanner and the room makes this a very laborious task. And so it's pushed physicians to make the decision about empiric full dose anticoagulation therapy without a full diagnosis. And it's great when you do a TEE and you can see a large central pulmonary embolus, but when you don't, and you see a large dilated right ventricle with an RV-LV that's very big, you gotta sometimes make that presumption. And that's kind of like, you're all so young, but I'm not that young. We used to do that before CTs were that readily available. So I've learned a great deal about this, and I thank you all.
Okay, that's great. And thanks to Boston for supporting the call. We've learned a lot from the microvascular to the macrovascular to the underlying pathologies that are underpinning the reaction to this virus. And I've allowed the call to go on a bit longer than we should have, just because I could have talked all night, to be honest. It's fascinating. We've got so much experience and different approaches to this disease according to our specialties and our backgrounds. I'm really grateful for everyone giving their time. Hopefully we'll be able to edit this and put this on the internet for other people to see. I'm grateful for the attendees who came. A lot of them asked the questions that subsequently we were able to tease out in the conversation, and so I'm grateful for those who submitted questions via the Zoom function, and hopefully we've answered most of them. Apparently we're supposed to finish every conversation with keep safe now, so keep safe. We don't want this virus, and we certainly don't want you to get sick. And thanks, Beverly, for your really fantastic talk. And to everybody, and great for logging on. Thanks to Boston for support, and nice to see you.
Thank you.
Thank you.
Bye-bye. Take care.
Yes.
Bye-bye.